I'm going to talk about the total knee replacement and the amputation to finish up our PowerPoint from Wednesday that we ran out of time for. The knee arthroplasty meaning joint replacement. So a knee arthroplasty was a replacement of that joint, usually due to breakdown of the bone and pain. So our goal is to restore the motion of the joint to relieve the painful condition. It could also be to correct a deformity if there was an injury to the area. Usually we would use some kind of compression bandage like an ACE wrap or an immobilizer to protect this joint after the joint replacement until that joint's strong enough and repaired. So sorry, I'm learning this system. Total knee, some of the nursing interventions, we would expect our patient to come back with some pain and have a pain management plan in place. It might be a PCA machine, so teaching them how to use that and making sure that they're getting their dose of pain medication. Usually it's going to go from IV pain medication to PO as they're improving. Frequently this patient will have a trapeze on the bed to help themselves mobilize. They might also have this continuous passive motion machine, CPM machine. It's a big machine that goes the entire length, is fitted to their leg, and this machine bends where their knee is. And the goal is to maintain their joint mobility, both in extension and flexion. So it will be set up by the physician by how many degrees they're supposed to have flexion, and then how many hours they're supposed to be in that. So physical therapy will measure it and set it up, and it's also up to us to know how to use it, because at some point the nursing staff will take over putting the person in and out of that CPM device. You can imagine having this right after surgery increases the initial post-op pain, but it's good for the joint long term and really helps them decrease the edema to the site and improve their long-term function. So we do need to watch for the skin, though, because this is like a metal device that goes all the way up to the inner thigh. We have to be sure that usually they'll put some kind of sheepskin or some kind of padding over it to protect the patient's skin, and we as nurses need to just make sure that the skin doesn't become excoriated. It's a little difficult to sometimes manage, bedpan or getting up and down to the bathroom. So we want to make sure the area remains really clean. And then the first dressing change will usually be the physician's, and then they'll order us to do it. We need to make sure we're using aseptic technique and improving the patient's diet from the post-op period to help with healing. So amputations, it could be part of or the entire extremity that's involved. It can occur one after the other, kind of march up the leg if it's for a diabetic or arterial healing problems. Some of the indications for this situation would be peripheral vascular disease, especially atherosclerosis in the artery, where there isn't good oxygenated blood flow to that lower extremity, especially the foot or ankle area, and the person gets a sore on there and they are unable to heal it, and then that area becomes hypoxic ischemic necrosis, and then we have to amputate that area. So vascular changes due to diabetes are a big reason why amputations occur, especially as you see in this picture, like the toes first and then the marching up the leg with a partial foot amputation and a BKA. Usually the surgeon is going to go to where there's viable tissue. And so determining that. Another reason, or other reasons that there could be amputations, are for malignant tumors of the bone, such as Ewing's sarcoma or other osteosarcomas. For congenital deformities, especially say if we were going to try to match this person up to a prosthetic device, we might need to remodel a part of that limb to fit that prosthetic device. Could be also severe infections such as sepsis, where there's a vasoconstriction to the extremity that causes necrosis, hypoxia leading to necrosis, and the tissue doesn't remain viable, so we would have to amputate that area. Amputations can also occur, as a part of a trauma from an accident, such as a work accident or a motor vehicle accident. It could also be as a result of war injury like the IED. We've had a lot of this happening in the last decade with Iraq and Afghanistan wars. Could be as a result of a terrorism incident like the Boston Marathon bombing. There's always a psychological implication for our patients that have an amputation, and we as nurses are looking out for how their psychological state is, because it affects their healing process too. I mean, not just that we have compassion for them, but we want them to be able to look forward and try to think of some of the positive things instead of only the negative. But it's very tough. If it's been a traumatic injury, the person will not have had any time to prepare, and so all their grief comes after it's a done deal. Traumatic injuries can happen in young people or children or older people. With the older person or a person with a chronic condition, they can become so depressed because they see like the toe is going and foot is going. They're doing what the physician asks of them. They don't understand how to do anything better, and they feel like their life is over. It can really affect their independence, their ability to maintain their self-care if they have a BKA, below knee amputation, where they can no longer mobilize themselves on their own. And possibly they might not have support. It may even lead to them being hospitalized in a long-term care facility. Surgical amputation has specific goals, and that is to remove damaged tissue and to preserve the function and length of the limb as much as possible. If amputation occurs at a joint, it's called a disarticulation, and you'll see that on the graph on the next page. An open amputation is called a guillotine amputation. A closed, so it has a flap that's sutured or stapled, is a closed. And then the level of the amputation is determined by many factors that are specific to whatever incident is occurring. But keeping in mind these goals, they have to stay in the viable tissue area for healing of that wound. So goals for surgery are, if it's a traumatic amputation especially, is repairing the area, cleaning the area, and closing it up. So preoperatively, we want to educate the person on the reason and the plan as much as we know about what's going to occur postoperatively. For example, if they're going to come back with an ACE wrap on, if a prosthetic device will be used, which is happening more and more, because if you put a prosthetic device right on, that limb will mold to that prosthetic device more effectively than if you're putting it on, say, 6 months later. However, if this is a non-healing situation, we're not going to be putting a prosthetic device right on that wound. Also, we want to be sure that preoperatively they have an idea about what the plan is to deal with pain, so that when they wake up in pain or having pain and that fear and anxiety, that we are on the same page with them and can communicate with them about it. So we want to come back, when this person comes back to us, we want to have the PACU nurse come to the room and together do a bedside report, at least as far as looking at the site. We want to make sure that what they're telling us the situation is exactly what we're seeing, and we're able to answer and ask any questions, such as, we're going to look underneath the limb to make sure that there's no bleeding underneath that. Has that dressing been reinforced? Did it become saturated? I haven't seen very many amputations where there's actually drains to the site, but just making sure that the bleeding is controlled. And then the respiratory status postoperatively, their blood pressure, of course, all their vital signs, what their level of consciousness is. We want to make sure that what we're seeing is what the nurse is expecting, having gotten the preoperative report. And that, if this is a traumatic situation, is there a risk of infection, or what was the situation? Most amputations will have compression bandage, like an ACE wrap over the area. And it may be, and that's usually kept over the area until the area is well healed. We usually elevate, at least for periods of time, these amputation sites to decrease edema and swelling to the area. But I have to keep in mind that if their hip is always flexed for like a above the knee amputation, that they may get a contracture there. So we'll also turn them prone in bed a couple times a day or once a day, or at least not have their leg elevated in the same position, so that hip becomes extended and not just flexed. So if a prosthetic device is going to be used right away, sorry, this slideshow is going on its own. If a prosthetic device is going to be used right away, we're going to want to know how that works, and we're going to want to have some instruction from the physician about when it's going to be put on, how long. We want this person to be medicated for pain and including phantom pain, which I'll talk about in a minute. And we want to plan for mobilization for them. So slide board transfer, we want to be involved when the physical therapy is teaching them, because it's going to come to nursing to be involved in that as well. And we're going to strengthen the parts of their body that are remaining, especially their upper arms if it's a leg amputation, for use in a wheelchair or using a walker for mobilizing themselves. And we want to keep safety as a priority for this person because they're not used to the situation that's going on, and they maybe get frustrated with things. So this is just a diagram of where amputations can occur and what they're called. You don't need to remember this, memorize it or anything, but just to connect you with it. So phantom limb pain, the brain still thinks that there's a limb. There's still nerves going to that limb, and sometimes the pain can be excruciating, even though the person cognitively knows, I don't have a hand anymore. They took off that part of my leg. They feel it. It can be burning, crushing. It can feel like it's asleep. It can feel like it's in a weird position. It causes a lot of stress and anxiety. It doesn't make any sense to them. So we want to medicate them for pain. But some other things that may help as well are this mirror therapy. So trying to show the brain to hands will help this pain stop happening. And pain interventions, not just medication, but other types of psychological support such as distraction, relaxation, possibly pet therapy, and visualization, those kind of things. We don't want to forget that there's a lot to the psychological health, not just giving them pain medications. So prosthesis, are we going to be using a prosthesis? When is it going to be fitted? One of the big things about using a prosthesis is we don't want there to be any edema, because this edema will cause decreased tissue healing. It can cause the prosthetic device not to fit. So sometimes, frequently, it's going to take 6 months to get the prosthesis there, and that's in a person who's healing well. And so it's just a bit of time that they have to adapt to this limb situation before a prosthesis can be involved. Like I said, more modern use of prosthesis is to put the prosthesis right on after surgery. So you may see a different world that's evolving as we speak. Physical therapy is responsible for measuring, ordering, and placing this and teaching the person about it, but we also need to be involved to help the person, because the physical therapy comes for like half an hour, and then it's up to us and the patient. So we want to monitor for any rubbing, any excoriation of the skin, any changes in the skin, making sure that prosthetic is not going to cause any other injury. And if that limb is not well healed, it can open up the incision areas and be a real problem. Prostheses can encourage independence and help the person be more have more of the life that they had envisioned. Of course, it takes some getting used to. So it takes a lot of energy to deal with the prosthesis. There are people for whom this may be too much of a reach, giving them a prosthesis, because above just getting around with your normal body takes 40 to 60% more energy to get around with the prosthesis. So if the person's 80 years old, diabetic, fall risk, it may not be the right person to have a prosthesis. That's up to the patient, the family, the physician as well. So with the wars in Afghanistan and Iraq, we have had a lot of veterans come back with missing limbs from IEDs and other types of explosions and accidents. And the prosthesis world is really expanding because of the use of small computerized, chips, and our understanding of how the brain works has really helped us to offer people with amputations more mobility, more independence. And you've seen that in the Olympics as well, with people competing in the Special Olympics. So I hope that helps, and thank you.